Oh, this is probably the latest set.
Yes, sir. Yes, this was one
Okay.
is the latest one.
So let's
So
go
Ajit, you
quickly.
can skip these slides you have read previously and continue with new slides.
Yeah, this
Yes, sir. I want phenomenon here.
so I don't know, Ajit, let me know if when you want me to stop and you want to add some comments to what you already had said.
So maybe, sir, we should discuss aspergillosis in detail. You start with the aspergillosis.
Yeah.
Go backwards, sir.
Sir.
Yes, stop.
So now, come to aspergillosis, sir. These are the common species of aspergillosis caused by annihilation of conidia, which germinate into hyphae and invade host tissues. A spectrum of manifestation, allergic reaction, colonization, and senses localized infection of lung and invasive pulmonary disease, or disseminated lung, brain, eyes, and bones. These are the different disease states: allergic hypersensitivity and saprophylatic non-invasive, chronic invasive. These are the allergic bronchopulmonary aspergillosis is a hypersensitivity disease from immunologic sensitization to aspergillosis antigen. Inhalation of conidia caused by non-invasive colonization. Airways manifests and as wheezing and fibrosis. How can we diagnose positive skin prick and raised IgE, peripheral eosinophilia, and detection of fungal elements in sputum? It is treatment.
No, sorry, Ajit, I just wanted to, I'm sorry, here I want to make a comment before you go on. So, of course, in the so aspergillosis, yes, can cause the so-called farmer's lung or can have an allergic reaction. But of course, in transplant, because of immunosuppression, we don't really see this picture. And I just wanted to stress the fact that steroids, when you have a patient with aspergillosis in post-transplant situation, it's always dangerous. So yes, allergic bronchopulmonary aspergillosis is something that exists out there, but it's not really something that that is a concern when it comes to patients post-transplant. We mostly see invasive fungal disease. So invasive aspergillosis with pulmonary nodules. And as you said in the previous slide, that can also affect other organs, particularly the brain. And this is the reason why we, as you may remember, we don't use a lot of ambisome. We prefer to use voriconazole because there are studies up there that show that there is no major difference in terms of efficacy between voriconazole and amphotericin B, but voriconazole penetrates well central nervous system, the eye, penetrates well, the whole body is better tolerated than is normally, and it can be given orally. And that's why we recently had, you remember, a young child with aspergillosis is much better, and he did fine just with voriconazole, if I remember correctly. And that's why so essentially, and then the other thing I wanted to say is that we don't use galactomannan routinely because you can have false positives. It's not really very reliable. So really the most reliable test for aspergillosis is the CT of the chest. Doesn't necessarily have to be with contrast. And but of course, if you do it with contrast, it's better. But and then the last thing I wanted to say is that it is almost never you will find, as opposed to Candida, aspergillosis will essentially never be found in a blood culture. It would be extremely unlikely. I've never heard of it. Okay, so yeah, you can continue.
Yes,
Ajit.
sir.
So I'll go to the next slide.
Yes, sir.
Yeah, itraconazole, we used to use it, but really voriconazole or posaconazole, which is another form of oral antifungals, are preferable to it. That's why itraconazole, we used to use it, but now we don't use it really anymore. Okay.
That is the saprophytic non-invasive pulmonary aspergillosis. Fungal hyphae proliferating in the pre-existing cavities due to chronic lung disease can present with fever, cough, hemoptysis. So diagnosis serum antibodies against aspergillosis, and finding in the HRCT thickening of bronchial wall and mass. It is treatment in itraconazole and voriconazole. Invasive pulmonary aspergillosis, most common form, primarily disease of immunosuppressed host, such as after HSCT, chemotherapy, high dose of steroids, and solid organ transplantation. Patient can be present with fever despite on antibiotics, and coughs, chest pain, hemoptysis, pulmonary infiltratus can be vague in immunosuppressed patients. That is a criteria for invasive fungal infections, proven, probable, and possible. In the proven, histological or culture evidence and sterile material, and probable host factors, neutropenia, mycological criteria, direct cytology culture of non-sterile material, or indirect tests, glucomannan or beta-D-glucan. Possible host factors, clinical criteria. Serological marker of infection, ELISA of glucomannan is specific for aspergillosis. Molecular biomarker in serum, bronchoalveoli lavage, and cerebrospinal fluid. Beta-D-glucan assay detects fungal infection, but not differentiate between species. Blood culture is less sensitivity. See in this picture, chest X-ray and pulmonary aspergillosis, multiple findings are multiple nodules present in the chest. And in HRCT, hollow signs are nodules surrounded by the ischemic over time in the fungal mass sign with lung necrosis. It is treatment voriconazole 6 mg per kg for first 24 hours, then 4 mg per kg IV or oral, and BID. Guidelines recommended alternative treatment includes amphotericin B and liposomal and lips formulation. Now come to Candida. Candida infections, especially those caused by Candida albicans, were recognized as especially common during the early post-HSCT in the 1980s. During this period of time, before the introduction of fluconazole prophylaxis, the incidence of invasive Candida is estimated 11% with associated 39% mortality. Now, after introduction of prophylactic use of fluconazole, incidences are dropped 8% in the allogenic HSCT. Most common form of invasive candidiasis infection in BMT patients involve lung, spleen, kidney, and liver and more than 50% cases of voriconazole proliferation HSCT patient have benefits over fluconazole as prevent mold infection, neutropenia, broad spectrum infection, total parental nutrition associated with CVC related candida infection. I see in this picture oral candida. This is oral candidiasis, and this is
Yes.
investigation of invasive candidiasis blood culture. Beta D glucan is positive in fungal infections, but not specific. And HRCT findings. HRCT and candida, the lesion and nodules surrounded by the ground glass opacity. That is the treatment of candida infection, canocona empirical therapy in moderately and ill patients. And fluconazole is a susceptible organism, and in less ill patients, amphotericin B and liposomal is susceptible. And definitely antifungal infection depends on susceptibility testing results. That is the voriconazole and fluconazole doses at mg, voriconazole 8 mg per kg per day, and fluconazole 12 mg per kg per day, amphotericin B and lipid complex, liposomal and polarized depressors. Mecanofangan, those have 2 to 4 mg per kg per day, and caspofangan 50 mg per meter square per day. And now, pneumocystis jealousy pneumonia. The large spectrum analysis reported an incidence rate between 0 and 2.5% in allogenic HSCT recipients and 1.4 in autologous HSCT recipients. Hello, sir.
Dr. Lawrence, something happened. The presentation is not visible.
I think there is an internet interruption from Dr. Lawrence's side. So we better wait. He is here. He is visible.
Rajesh, continue.
Yes, ma'am. Pneumocystis jirovecii previously classified as a Pneumocystis carcini and classified as a protozoa. Currently, it is considered a fungus based on nucleic acid and biochemical analysis. Most human infected before 4 years of age. An immunocompetent host infection is asymptomatic and controlled by cell-mediated immunity. This histopathologic picture of pneumonia in immunocompromised host shows diffuse as alveolar pneumocystis. The sign symptom of pneumocystis jirovecii, fever, tachypnea, dyspnea, hypoxia, and suprasternal and intercostal region, cyanosis and respiratory failure diagnosis. How can we diagnose it? Established with the identification of organisms obtained by bronchoalveoli lavage, tracheal aspirate, and a bronchial lung biopsy, and bronchial brushing, open lung biopsy. See in this picture, the investigation in chest X-ray, the bilateral diffuse interval and develop ground gloss way. And then HRCT, the bilateral or unilateral patchy ground glass opacity. Now, the treatment of pneumocystis jirovecii, the TMP and SMX and pentamide isoniazid 4 mg per kg per day, and the hepatic dysfunction, hypo or hyperglycemia, rash, thrombocytopenia. How can we prevent from fungal infections? Environment culture of BMT units and air culture in BMT units, use of HEPA filters, practice good hygiene, and use of particle detectors for the particle counts. This is the levels good, good, module, and healthy, unhealthy, and very unhealthy, and hazards in the per meter squares. This is the particle count of ant BMT, and there are the good and healthy counts seen in this picture. Next, nursing management. Maintain good oral hygiene, bath alternative days, daily change of bed sheets, and use of sterile bed sheets and patient dresses. Avoid from humidifications in patient room. Educate patient to take healthy diet, steam inhalation. In case of respiratory distress, deep breathing exercise, tape sponging in case of fever. Any question?
Only a consideration. In my unit, we don't use sterilized sheet, but you change the sheet every day, or se necessary, more times a day. But we don't use sterilized sheet.
Hello, sorry, sir.
In my unit, we don't use sterilized sheet, but we change the sheet every day or more if necessary. Just a consideration.
It's the, I think, yes, Sitrajra, you can comment.
Hello. Hello.
Yes.
Yes, Marco.
we are changing bed sheets daily, and if necessary, at the moment we change at once. And it's from the laundry. It's they are using the high, I mean, voltage to press and iron of our units bed sheets too.
It is not sterilized, Marco. It's not sterilized,
But it's pressed, but
it's
they are,
pressed and iron.
when yes, when they iron, they use good.
No, we don't use sterilized sheet, but every day you change the sheet, and you have a laundry that wash the sheet at high temperature, but not sterilized.
Yes.
And
yes, Marco, yes, we do change sheets every day, and if required, more often. This is what Sister Azra and Dr. Noor was conveying, that we always ensure this thing that we change every day patients' bed sheets.
No, but I think Marco was making the point that in one of the slides, Ajit said that one of the measures is to use sterilized bed sheet, but probably it's a lot of work to sterilize.
Yeah, we are not using it.
Okay.
Yes, Dr. Norris agreed.
Yeah.
It's
Okay.
we are not using sterilized sheets, but maybe I think they Ajit has seen some recommendations, so he has written this thing. We are not using the sterilized bed sheets, but we are using properly ironed bed sheets, and we always use fresh for every day for the admitted patient and even for the OPD.
Okay, so I wanted to make a comment. So in our specific patient population, and particularly for the low-risk transplants that we do most of the time, that is to say, matched sibling transplants with the patients with thalassemia, we, even if we have done many transplants in non-HEPA filtered room, the incidence of fungal infection in our experience is around 4-6% of aspergillosis, but a lot of that, the few clusters we had were probably related to some particularly high aspergillus load in the air. So we had a problem like this in Bangalore, and also I believe in Islamabad, maybe you had one room in which there was probably, and so that's why counting particles, which is very easy, very inexpensive, and you can do it very frequently, multiple times a day. And as you know, the aspergillus spores, they are roughly 2.5 microns. So, so I think that even though there's not a lot of literature and we could do a proper study, I think, and of course, we should do it in parallel with also maybe some surveillance culture of the environment and the air. I think the particle count is something that I believe could be very useful and really help in preventing those high loads of aspergillus that also in low-risk patients like ours can actually cause infection, and sometimes, as doctors in Islamabad remember well, patients can die because aspergillus tend to invade the blood vessels, and they can have pretty bad bleeding from lung lesions.
Yeah, totally agree. And actually, when we have started the particle counting on your advice, actually this has sensitized all staff members, and initially we were observing higher particle count, but with the stringent what you can say cleaning practices, we have achieved a lower count. So this is a very good practice, and definitely with the if we do the prospective study, and again, as you have mentioned, along with the air cultures or environment culture for fungal infection, this would be a very interesting study.
Maybe Sandeep, I don't know if you're there, if you can, I saw that you also have done some measurements in the new transplant unit in Bangalore, and I think that, which is HEPA filtered and positive pressure, and I think the particle count is extremely low. Correct, Sandeep?